Բարի երեկո, հարգելի ներկաներ։ Իմ անունն է Աստղիկ Աթանյան, ես ներկայացնում եմ Հայաստանի Ամերիկյան համալսարանի Turpanjian առողջապահական գիտությունների ֆակուլտետը եւ կլինեմ այսօրվա միջոցառման համակարգողը։ Ես խոսքս կսկսեմ հայերենով, կներկայացնեմ համաժամանակյա թարգմանությունից օգտվելու հիմնական կետերը եւ այնուհետեւ կանցնեմ անգլերենի, քանի որ ինչպես նախապես նշվել էր, հայտարարվել էր միջոցառման լեզուն անգլերենն է լինելու եւ ամբողջ ընթացքում տրամադրվելու է համաժամանակյա թարգմանությունը անգլերենից հայերեն եւ հակառակ հարիքի դեպքում։ Yes, Good evening, dear guests. My name is Astrid Katanian. I represent Turpanjian College of Health Sciences at the American University of Armenia and will be the moderator of today's event. I will start with short speech in Armenian, guide the participants on how to use simultaneous translation, and then switch to English since, as it was announced, the language of the event will be English. Meanwhile, I guess we already have participants who are English speakers. Dear English-speaking guests, you're welcome to also use translation from Armenian into English simply by clicking on the globe sign on the bottom of your Zoom screen and choosing English as your language of preference. Եվ այսպես մեծ սիրով ողջունում ենք ձեզ Հայաստանի Ամերիկյան համալսարանի եւ Բոստոնի Հայ-Ամերիկյան բժշկական ասոցիացիայի համատեղ ուժերով կազմակերպված կրթական միջոցառմանը լյարդի ոչ ալկոհոլային ճարպային հիվանդությունը եւ դրա վարումը առաջնային օղակում թեմայով։ Հարգելիներ, նախ եւ առաջ թույլ տվեք ձեզ ուղղորդել, թե ինչպես է հարկավոր օգտվել համաժամանակյա թարգմանությունից։ Ձեր բոլորի Zoom էկրանների ստորին հատվածում դուք կտեսնեք գլոբուսի նշան, որի ներքևում գրված է անգլերենով interpretation կամ ռուսերենով ինտերպրետացիա։ Սեղմելով այդ կոճակի վրա կտեսնեք լեզուները։ Տվյալ դեպքում կտեսնեք անգլերեն եւ հայերեն տարբերակները։ Պետք է ընտրել այն լեզուն, որը ցանկանում եք լսել։ Այսինքն տվյալ պարագայում ենթադրում եմ, որ հայերենն եք ցանկանալի լսել։ Հարկավոր է սեղմել հայերեն լեզվի վրա եւ այս պարագայում տեղյակ եղեք, որ դուք լսելու եք իրական օրիգինալ ձայնի մոտ 20%-ը, որը կարևոր է ձայնի ինտոնացիա եւ այլնի համար, որը դուք եւս ազատ եք անջատել, եթե դրա կարիքը լինի։ Սեղմելով դրանից ավելի ներքև գտնվող mute original audio, անջատել օրիգինալ ձայնը կոճակի վրա։ Ես նաև ցանկանում եմ հիշեցնել, որ տվյալ միջոցառումը ձայնագրվում է եւ ձեր մասնակցությունը այս միջոցառմանը ենթադրում է համաձայնություն ձայնագրությանը։ Okay, very well. I guess we can start the actual event. Welcome, dear participants, to the educational event jointly organized by the American University of Armenia and Armenian American Medical Association operating in Greater Boston area. With this event, we gladly announce the launch of a series of educational events on various hot topics in health field, of course, which aims at providing an educational and also experience sharing platform between healthcare professionals of Armenian origin living and working in the US and healthcare professionals living and working in Armenia. This lecture series has been made possible by funds made available to Armenian American Medical Association by a generous donor in the United States, and we're very much grateful for this general donation. The first event, which is today's event, will be on the topic of non-alcoholic fatty liver disease and its primary care management. I am glad to announce that it is going to provide one continuous medical education credit to senior healthcare providers who participate fully in this event. Just before we proceed, just a couple of technical announcements. I would like to ask all participants to mute their voice and turn on the microphone only when speaking. For example, during discussion or when we ask to share your experience and you're willing to. Also, in case if you are a candidate of credits, so you want to receive continuous medical education credits, please make sure that you are present during the whole event, and also you are using your full name when you enter this session, because otherwise we cannot see that this particular person participated in the event and cannot prove it to the Ministry of Health in order to provide credits. Someone has started to share screen. Someone started to share screen. Could I ask you to stop sharing?
It's an AAMA-AUA.
Okay.
Yeah.
Let me try to stop sharing the screen. Ophelia Makarchan, okay, thank you very much.
Okay, she stopped, yeah.
Okay, very good. We can proceed. Just a little bit about agenda for today. What do we have in the agenda? We will start with clinical case presentation by Dr. Ara Ajemian. And then we might have a small discussion part when, we ask you to share your experience in case if you would like to. After that, we will proceed with a lecture on non-alcoholic fatty liver disease by Dr. Rafik Aragozyan, after which we will have Q&A session. And by the way, in order to have a full Q&A session and use our time effectively and efficiently, you already, some of you, mentioned your questions in the registration form, which we already collected. And you're always welcome to write down your question in the chat, addressing that to everybody. Okay, so that we, at the end, we can sound those questions and start discussion, actually. At the very end, we would like to ask you to share your thoughts about this event and fill very short evaluation form so that we make sure that the future similar events are following your expectations. With this intro and welcoming remarks, let me give the floor to Dr. Ara Ajemian, who is primary care physician and medical director of primary and urgent care at Valley Medical Group, Montvale, New Jersey. Dr. Ajemian, floor is yours, please.
Hello, thank you for having me here today. Thank you for inviting me. It's a great pleasure to be part of this important event today. So I guess I'm going to share my slides. Screen. All right.
Okay, we can see.
You can see. Okay. Well, all right. So basically,
perhaps we could proceed with slideshow mode.
Sure. You don't see it?
No, we see it, but not in the slideshow mode. Just from the first slide. A bit left, there is slideshow.
It says animation, transition.
Right from the animation, there is slideshow.
From the beginning.
Yes.
Okay.
Sorry.
Very well.
Mm-hmm.
All right. So, of course, as you know, this topic is very common in primary care. We often see elevated aminotransferases or elevated liver function tests. It's quite common in the general population. Is estimated to be 20%, and of course in healthcare it's much more than that because our patients have medical problems that put them at higher risk of developing fatty liver disease. So I'm going to present
Ներողություն եմ խնդրում, որպեսզի թարգմանությունը լսեք, Սեղմեք լոբուսի կոճակի վրա եւ ընտրեք հայերեն տարբերակը, հայերեն լեզուն, ընկերներ։ Excuse me, Dr. Artemyan.
It's okay.
We can proceed.
All right, so this is a typical patient that most of you have seen and see every day. So here's an example. This is a 68-year-old woman, and her past medical history includes renal calculi or kidney stones. She also has hyperlipidemia, and she has obesity with a BMI of 34.5. She does not have any allergies. Her medications are the following. She takes Lipitor or atorvastatin 10 milligram every day. She is on Prilosec, omeprazole 40 milligram daily, and she takes a multivitamin. Her social history, she was a smoker. She quit 20 years ago. She drinks 1 glass of wine every day. Her vital signs show that her blood pressure is elevated at 140/70. Her pulse is normal at 88. She weighs 97 kilograms or 214 pounds, and BMI is 34.5. Her physical exam, unremarkable, normal head and neck exam, normal chest, clear lungs, normal heart sounds, and abdominal exam is completely normal, no swelling in the legs. And these are her laboratory assessments. Her AST is elevated at 52. Her ALT is elevated at 70. Her hemoglobin A1C is 5.8, which puts her in the pre-diabetes range. Her CBC is normal, including a normal platelet count of 190,000. Her renal function is normal. Apart from the AST and ALT, all the other liver enzymes, including bilirubin and alkaline phosphatase, are normal. Her cholesterol is slightly high at 210. Her HDL is low at 35. Her LDL is slightly high at 135, and her triglycerides are slightly high at 175. So, as you know, this is a very typical patient that you have all seen, and I just want to pose some questions to the audience, not necessarily to answer them right now, but I think this would be a segue to Rafi's presentation. So my questions that I want to leave you with are the following. How often do you see abnormal liver function tests when you order routine labs? How confident are you as a primary care provider in evaluating these abnormal liver function tests? Now, what should I tell this patient? Should I tell her she just has fatty liver and she just should lose some weight and that's it? Or is it something more serious? And what should I do? What additional tests can I order? Should I look for hepatitis B and C? Should I question her alcohol intake? Perhaps is she drinking more than 1 glass of wine or not? Are there any other liver diseases I should look for? And what tools do I have? So what tools do we have that can help us decide which patient has simple fatty infiltration and which patient will progress and has lipotoxicity and inflammation, which will lead to fibrosis and cirrhosis? And how do we make that distinction? And then finally, how can I do better? How can I manage this patient's metabolic risk factors? As you saw, this patient's blood pressure is a little bit high. Her lipids are not well controlled. She is pre-diabetic and she is obese. So how can I help her reduce those risk factors? And will that improve her liver function test? Will that prevent severe liver disease? So that's it. So I just want to stop here, and then we can move on to, of course, Rafi's presentation. And then perhaps we can come back afterwards to see what tools we can use for this patient and what do we do? What's the plan of action?
Excellent.
Right. So I'm going to stop sharing now. Is that okay?
Thank you very much, Dr. Artemyan.
Yes,
Now,
thank you.
Thank you very much. Now let me give the floor to Dr. Rafik Alagozyan, Assistant Professor of Medicine at Tufts University School of Medicine and attending physician in the Division of Gastroenterology and Hepatology at Tufts Medical Center, Boston, Massachusetts. Dr. Karagozyan, thank you very much for being here, and floor is yours.
Yes, first of all, I would like to thank the Armenian American Medical Association of Boston for organizing this this talk, and I thank you for the invitation. This is, I think, a very relevant talk for most providers because of such a common condition that is seen everywhere. And thank you, Dr. Arjemian, for the introduction of this case. I will give some thoughts about this, if I may. So, as you pointed out clearly, these type of patients can be seen regularly. The case that you provided had all of the classic metabolic profiles that we look for in fatty liver disease. All of the above meet criteria for increasing your suspicion for non-alcoholic fatty liver, including the prediabetes, the elevated BMI, high blood pressure, dyslipidemia, and so forth. But to answer specifically what to do next, of course, we can jump to fatty liver as a possible etiology. However, we have to be somewhat thorough and make sure we exclude other causes. For example, so in my approach, before I conclude and say this is non-alcoholic fatty liver disease, I want to make sure viral hepatitis B, C is ruled out, depending on their demographics, depending on what country they're born, where they're from. Hepatitis B or their risk factors, hepatitis B can be more prevalent. You need to rule that out. Simple things like making sure their iron level, iron metabolism problems are excluded. And then very importantly is to get a very detailed history. I know this is done in primary care office. It depends again how well you know the patient, how long have you been following this patient, because sometimes patients may not be forthcoming in terms of their alcohol intake. So understanding their alcohol use and whether that is contributing to liver test abnormalities is key. So getting a detailed history about those type of lifestyle habits, as well as understanding whether the patient may or may not have autoimmune conditions. Again, now we're going outside of the box of other list of causes of liver disease, including autoimmune or more rare cause of primary liver conditions. And finally, making sure you get a detailed medication list. Of course, you know, as a primary care, you know what your patient is taking, but sometimes they may be taking supplements, they may be taking herbals, they may be ordering things online, which you may or may not be aware of, and that this can contribute to a very common cause, drug-induced liver injury. It can be from typical medications that you have prescribed, or, as I said, supplements. So that should be the sort of the initial steps. And then once you've kind of excluded all that and you've determined that there's no other causes, then the focus could be on metabolics. So that's sort of the way I proceed with this this type of case.
Very much.
Okay, thank you very much. Should we proceed with the lecture, or should hear the audience, or we would leave the questions to the very end for the Q&A session? That would be the right way to proceed. Okay, thank you very much. Dr. Karagözyan, please, the floor is yours for the lecture.
Sure, I can share. Okay, am I in presenter mode?
Yes.
Thank you. Okay, so what we will today's topic again, what I'm going to give is a more updated terminology. You know, we're not actually calling this you know, here in the United States or in a lot of parts of the world, we're not calling it NAFLD anymore. We're calling it steatotic liver disease or MASLD MASH. So these are some terminology changes which I will go over and describe further. I have no disclosures for this presentation. So the objectives of today's talk include understanding the global prevalence of steatotic liver disease, understanding the natural history, reviewing changes in nomenclature, reviewing screening guidelines, discussion of non-invasive markers for risk assessment, as well as understanding what dietary pharmacological management is there for this condition, and reviewing current approved pharmacological therapies, at least if it's accessible to you or available to you. So just so you understand, because of the terms are interchangeable, NAFLD, again, it's based on older papers prior to 2022, the term NAFLD is being used. So this is the global prevalence of NAFLD. It's essentially found across the world, essentially around a quarter of the population in different regions have this condition, and then about 15 to 20% of patients who have fatty liver disease have a active inflammation of the liver, which is described as NASH, and about 10 to 15% of these patients will develop or advance to a condition called cirrhosis, which is scarring of the liver. Again, these are more, this is a slightly more updated data that came out just this year, 2024, from UNOSI and colleagues that describe the prevalence of fatty liver disease, specifically in patients with diabetes. Again, I do want to emphasize that having diabetes, and I will review that again, increases the risk of this disease as much as you can see that 50 to 60% of patients of the population with underlying diabetes likely has NAFLD. So I think when you see a patient in your clinic with diabetes, there's a good chance that they're also going to have this comorbidity. And this is from the same paper. You could see that over the decades from 1990 to 2026, how the prevalence of fatty liver or metabolic associated liver disease, steatotic liver disease, has increased. And actually, over the last 5 years, with diabetes, the prevalence is up to 68% of having this condition. And I think, we sometimes associate this with particular parts of the world, but in reality, I think it can occur anywhere, as long as there's diabetes. This condition of non-alcoholic fatty liver exists. And as I pointed out, 40%, so 66% can have, patients with diabetes can have the inflammation. Around 41% will have significant fibrosis, and a small percentage have advanced fibrosis or cirrhosis. So why are we so concerned about fatty liver disease? Because it is associated with long-term adverse outcomes. Most particularly, one particular adverse outcome is liver cancer, hepatocellular carcinoma, and you can see. So we know that there's multiple kind of causes or reasons patients can develop liver cancer, but including hepatitis B, C, alcohol use disorder. However, this condition, fatty liver, is also a significant risk factor. It varies across the world, so you can see how it varies. But I think the take-home message is that it's a risk factor that needs to be paid attention to. So as you can see, this is a spectrum of disease. So essentially, what happens is that fatty liver can over time develop increase. So I think up to 5% of lipid accumulation in the liver is acceptable. It's not that necessarily pathologic, but when you start having greater than 5% of lipid accumulation, which will result in immune infiltration, and then this tends to develop collagen deposition, scar formation, and that will result in liver cirrhosis. Liver cirrhosis is also associated with high morbidity, mortality, associated with the need for liver transplant, as well as hepatocellular carcinoma. So this is why we pay attention to this disease. So so this is data from the United States, and it sort of shows, this is the green is sort of the current, as of the last 5 years, the current data and what is projected. So it's projected, this is again out of the US population, about 100 million to have a fatty liver disease, about 27 million to have NASH, which is the inflammatory part of fatty liver disease, and then about 10 million to have cirrhosis. Again, it's a small percentage, of course, but that's when most of the problems occur. The biochemistry and the biology of steatosis changing to fibrosis is complex. There are a lot of factors involved. To simplify, there's fatty acid beta oxidation, there's increased triglyceride storage, there's increased insulin resistance, hyperglycemia. Again, I think these problems are not necessarily unique for fatty liver disease. It's actually kind of the basis of metabolic syndrome, which can happen anywhere in the body, and eventually you have further oxidative stress. You have upregulation, worsening insulin resistance, and then this creates sort of changes in cellular architecture in the liver, such as Mallory bodies, Kupffer cells, which will lead to fibrosis, and collagen deposition, which is what cirrhosis is. So again, this is not a rapid process. I have to say this is a process that will take time. It could take up to 20 years, possibly. So it's sort of, when we see patients, we tell them that, you're not going to become cirrhosis, next month, but it's something that over time, if it's not attended to, will happen at some point. So cirrhosis, clinical outcomes in adults with non-alcoholic fatty liver, I think the important message here is that it's really based on fibrosis stage. So it's not only the fact that you have non-alcoholic fatty liver disease, it's what stage of fibrosis you have. Of course, the majority probably are low stage, meaning F0 to F2, no fibrosis. Then that's a transition to F3, F4. That's when liver-related events begin to occur. And some of you have seen patients with these problems. These are all complications of cirrhosis, variceal bleed, ascites, encephalopathy, HCC. And you could see that the risk factor increases when you have F4 cirrhosis, basically increasing fibrosis stages associated with increasing risk of liver complications. And again, this data is very similar. It's showing basically graphs of the hazard ratios of it changes between F4 and F2. So essentially the point I'm making with this data is that the greater your fibrosis stage, the higher your probability of all these various adverse events. So nomenclature consensus. So what I was referring to in the beginning is that we have some changes in nomenclature because we feel this was guided by the worldwide societies of hepatology, including the European, North American, Asian Pacific, and because this disease is somewhat of a mixture of alcohol and non-alcohol causes. So what we have now labeled it as steatotic liver disease, where you can have on the left predominantly metabolic, and the name of that is MASLD, which is metabolic dysfunction associated steatotic liver disease on the left, which can result in MASH. So one leads to the other, and then on the other side of the spectrum, you have ALD, alcohol-associated liver disease, and in the middle, so you can have a spectrum where increasing alcohol intake will lead to alcohol liver disease predominant versus not. So these numbers are weekly alcohol intake in grams. This is daily alcohol intake in gram. And I just want to, just for everyone to understand, one serving, for example, one serving of a beer, 330 milliliters bottle of beer is about 14 grams of alcohol over there. One serving of, let's say, vodka, about maybe 25 milliliter is that's also 14 grams. So we'll go over that in more detail. So again, these are sort of the name changes that we've done. I won't go into more detail, but the point is that the name has changed. So this is the alcohol intake that I do want to emphasize. And the reason why it's important is that patients can not only have metabolic associated liver disease, but they can have alcohol associated liver disease or a combination. So in the world, from a hepatology perspective, for males, it is one unit, as I said, is about 12 ounces or 330 milliliter, which is for an average male adult, up to 2 servings is acceptable, and about 1.5 ounces, which is I think about 30 milliliters of 40% alcohol is equivalent to 1 serving. So this is sort of the recommended daily intake. So how do we approach the steatotic liver disease? We first want to ask, as Dr. Ajamian pointed out with the metabolic criteria, are there metabolic comorbidities? Are there other diseases that will fit? So if it's yes, so we sort of go towards the more of the metabolic pattern. If it's no, then we start thinking about other causes of steatosis. And I do have to say that there are many other causes of steatosis except metabolics, which include alcohol, as I said, as also medications and other genetic contributions. Steatotic liver disease does have increased risk of all-cause mortality. So if we put as our reference group no hepatic steatosis, you could see that the hazard ratio becomes significant non-mast cell steatosis, there's no significant increased risk of all-cause mortality. But when you have metabolic and alcohol liver disease, 1.69, and then when you have metabolic dysfunction, your all-cause mortality increases. So the point here I'm trying to make is that as you have more comorbidities, your all-cause mortality overall hazard ratio goes up with a significant p-value compared to your control population of no hepatic steatosis. And similarly, we want to look at fibrosis score. Fibrosis score, which I will talk more about about FibroScan or transient elastography. That's another measure of fibrosis. But to simplify, let's say if you have that information, or if you have a pure liver biopsy, you can stage your patient between F1, F2, F3, F4, and this predicts 5-year risk of decompensation, meaning worsening liver dysfunction. And obviously, the higher your fibrosis stage, the higher the risk of decompensation is. And of course, there's other contributors of fatty liver, which I already described. So step one. So going back to our clinic patient, what to do in these patients who are at risk. So the most important, as I said, is to identify their metabolic risk factors. So if they have presence of metabolic risk factors, they have diabetes, they have by chance any imaging that shows steatosis, your next step is to take the detailed history, understand their alcohol intake, and then review CBC liver functions. Step 3 would be to do a readily available calculation of what we call the FIB-4. So the FIB-4 test is just a standard test that you can calculate from the labs that you have, and so it's basically, and I'll show you the formula. It's basically a calculation based on age, AST, ALT, and platelet counts. So that will give you sort of a determination of their risk profile. And based on that, you can sort of risk stratify them, whether they are low risk, intermediate risk, or high risk. Sometimes you may get a middle ground indeterminate risk, or sort of a gray zone, so-called. So that's when you want to do secondary testing. What is available here in the United States, we have liver stiffness measurements. It's called or FibroScan elastography. We can obtain that, and we can get what we call KPA measurements, and that will assist us further in determining what risk they fall in. This is the standard metabolic criteria that is necessary for you to look at. These are the standard data points that you have in your clinic already: the BMI, fasting glucose or A1C levels, blood pressure, triglyceride levels, as well as lipid levels. So basically, if patients have, the criteria has become a little strict. If patients have at least 1 out of 5, then you should be looking to assess for fatty liver. So as I said, the key point here with the tools you have in the primary care is to get a FIB-4. And if the FIB-4 comes back low, then you can reassess periodically, meaning you can check every 1 to 2 years for diabetes, pre-diabetes, while you check your hemoglobin A1C. And if they don't have diabetes or less than 2 metabolic risk factors, you can check the FIB-4 every 2 to 3 years. However, if if the FIB-4 score comes back high, for example, greater than 2.67, that's when you can, that puts the patient slightly in a higher risk for fibrosis, and that's when you can consider referring to specialty care hepatologists. And at that point, there can be additional testing done. That includes MR elastography, or even liver biopsy, because sometimes there can be situations where the testing is indeterminate. There's some diagnostic uncertainty, and so forth. So that's when we would recommend doing a biopsy. However, when you have this middle ground situation, it can either be managed in primary care or in specialty care. If primary care has access to FibroScan testing, that can be done and determine if the FibroScan comes back low or intermediate or high. So again, anytime it's intermediate or high, we recommend referral to hepatologist. But if FibroScan comes back under 8 kPa, which is the liver stiffness, then I think that is a situation where it can continue to be followed. I do want to say that there's an additional test called ELF test. This is available in most labs in the United States, where it's a enhanced liver fibrosis test, and that also gives a score of under 7.7 or intermediate or high. So this is the formula. This is the formula for the FIB-4. Here in our medical record systems, it's actually built into the chart, so we could kind of plug it in and it will give you the results. Obviously, if you don't have, there are apps on the phone you can download on your phone and just plug those values, the AST, ALT level in units per liter, and it will give you a FIB-4. So I think this is the most useful parameter that rules in or rules out or identifies fibrosis. There are other scores. I'm not going to go over it right now. NAFLD fibrosis score that has much more parameters, but I think the most validated one has been the FIB-4. I do want to mention one thing about that, is that because this formula is age specific, it breaks down a little bit for patients under 35 years old or over 65 years old. So the formula was really studied for sort of 36 to 65 age group with these cutoffs. So if you happen to have a very young patient under 35, or if you have an older patient older than 65, please be mindful that the cutoffs instead of 1.3 would be 2.0, because the formula includes age in the numerator. So alternatively, so when you have, so going forward, what else can we use to determine their risk of fibrosis, their risk of cirrhosis? We have elastography. So it's called vibration controlled transient elastography, or FibroScan. So this is useful, particularly in those patients that have slightly higher FIB-4 scores, or maybe their ultrasound has suspicion of fibrosis, or they have other reasons that you want to investigate underlying fibrosis. So this will give us this. Basically, it's a sound wave that passes through a soft organ, and it's most reliable in ruling out advanced disease. It's accurate in detecting advanced fibrosis. If your center, or if your hospital or your area does not have FibroScan, alternatively, ultrasound with shear wave elastography, which is which is basically in addition to the ultrasound machine. Most of the General Electric ultrasound machines can add a shear wave elastography component to it, and thus you can use acoustic radiation force technology, and you can obtain elastography with that. So it doesn't necessarily have to be the vibration controlled. If that's not available, you can use the shear wave, which is slightly a different physics behind it because it's acoustic versus vibration, and you can use that. And finally, I think the most accurate is MR elastography. This is again an upgrade to the standard MRI machine. Not all here in the United States, not all centers do MR elastography. So if that is available, that would be the most sensitive. This is an example of a FibroScan. So we get two scores with the VCT, the FibroScan elastography. We get a CAP score and we get a KPA, and there are references to this. This one example that I'm providing, both numbers are actually high, meaning that so the CAP score represents steatosis level, and the KPA score represents liver stiffness. So in this example of a patient who did a FibroScan, and we do about 10 measurements, and it's 10 to more, slightly sometimes minimum 10, and we get a mean average. So this is sort of the data behind the FibroScan. It's been well validated across fibrosis, and the KPA has shown to be very reliable in terms of these reference ranges. I do want to just point out the in hepatology there are many non-invasive testing that can be done depending on what's available in your area. Besides, as I mentioned, besides the FIB4, the ELF, we use that here quite frequently. It has to be sent to a reference lab. Obviously, there's cost behind it. The benefit of the FIB4 is no added cost. It's basically part of the routine blood work that the patient gets. And then finally, I summarized the various imaging components we have for non-invasive testing. The benefit of elastography here in our clinic is that it's point of care, meaning the patient has a visit with hepatology office. They can get basically a FibroScan at the same time. With acoustic ultrasound, you have, or the shear wave elastography, you have to order that with an ultrasound. So what is the role of liver biopsy? Of course, we do less liver biopsies nowadays than we did probably 20 years ago due to the advancement in technology in non-invasive testing. However, it can help us to decide if there's if the non-invasive testing is inconsistent, non-diagnostic. So we use this to stage fibrosis. We can also evaluate for certain other diseases, which obviously you cannot with non-invasive testing, specifically autoimmune, drug-induced liver injury. Usually you need a liver biopsy, iron overload issues. Those all of these can cause abnormal liver tests. So essentially, that's where the liver biopsy it comes into play. So currently, the guidelines in terms of the societies, European American societies, are not advising general population screening for NAFLD. However, based on presence of metabolic risk factors, obesity, patients should undergo primary risk assessment with FIB4. And again, I emphasize FIB4 because it's not an additional test. It's what you have already. There's no cost to it. and it's been fairly well validated. High-risk patients, you know, I think screening should only be reserved for the most high-risk individuals, you know, difficult to control diabetes, maybe family history of cirrhosis, you know, more than just mild alcohol consumption. These patients should be considered for screening for advanced fibrosis. Um, and the one thing to remember, liver enzymes may or may not be elevated, and they cannot be used in isolation to make a decision about what is their disease state, because we can sometimes see them elevated and sometimes we can see them normal. So this paper from diabetes literature showed the importance of diabetes as a risk factor, and again, it emphasized moderate to advanced fibrosis affects at least a strong percentage of patients with diabetes. So I think the take-home message here is that if you have a patient with diabetes, these are the ones that should be focused and have more closer evaluation for fibrosis. And you can here's a comparison of the diabetic population about prevalence of, so this paper found prevalence of in this cohort, proportion of patients with steatosis and fibrosis with elevated liver enzymes, and it was found that 70% had steatosis and 21% had fibrosis, and then you can see that the elevations in liver enzymes were present. So moving forward to what interventions can we offer? I think initially the main intervention includes diet and lifestyle modifications. So patients of note, all of our patients who have steatosis end up having referral to nutrition counseling to understand whether there are changes that can be done in their nutrition. So various different diets have been studied to understand what is most beneficial for fatty liver disease. And I do, you know, for the purpose of times, I didn't go over all the studies, but I do want to emphasize that very often the Mediterranean diet has been shown to be a leading beneficial diet for reversal of fatty liver. So I think if you have any, so besides having a consultation with the nutritionist, emphasize, you know, reviewing their what types of diet they pursue, and giving sort of counseling regarding this is something that may help in their steatosis. Of course, alongside diet is physical activity, and that has also been linked to longer physical activity, moderate to vigorous physical activity has been shown to associate with lower all-cause and cardiovascular mortality in this patient population with non-alcoholic fatty liver disease. So I think getting a good history from your patients, understanding how active they are, their mobility, and recommending increased physical activity is very important. Finally, now we want to move forward to therapies. So you know, we talked about sort of the disease process, what is the long-term complications of fatty liver, non-alcoholic or fatty liver disease. We talked about sort of lifestyle interventions. Finally, are there pharmacological interventions we can offer? So here in the United States, GLP agonists have been used very regularly now for metabolic syndrome, for obesity, actually diabetes and non-diabetes obesity with elevated BMI. However, back about several years ago, at least since 2021 and later, even 2023, there has been studies about semaglutide as one of the leading GLP agonists for improvement. However, unfortunately, these medications did not show significant improvement in fibrosis staging. So I think they're great for weight loss. They're great for improvement of diabetes, but do they necessarily improve fibrosis? That has not been determined or concluded from studies so far. That said, I will tell you from my personal experience and most physicians who treat metabolic syndrome or fatty liver disease, I think these are excellent first step interventions to improve their metabolic profile. Because as I pointed out earlier, not every patient has fibrosis, and if you happen to be in the earlier stage of fatty liver disease with only steatosis, with multiple comorbidities, obesity, this will most likely halt the progression and improve your risk factors. This study came out New England Journal, February of this year. This has been sort of a highly anticipated, highly weighted a medication that the hepatology community has been waiting for a long time. This is the first FDA, meaning the drug agency, regulatory drug agency in the United States, approved this medication specifically for non-alcoholic fatty liver disease with evidence of fibrosis. So this medication called resmetirom, again, just out for the last 6 months, is the first drug that shows reversal of fibrosis. So you could see primary endpoints. There were 2 primary endpoints that were studied: NASH resolution with no worsening of fibrosis. Here are the 3 arms: placebo, 80 milligrams, and 100 milligrams. And you could see that across the 3 arms, resmetirom 100 milligram showed resolution of NASH and no worsening of fibrosis over a period of time. This was studied in close to 1,000 patients over about a 12-month period. And then the second graph here showing fibrosis improvement by stage, again compared to placebo, this showed benefit, and alongside there was no worsening of the NAS, or the NAFLD activity score, which is based on histological or pathological markers. So I think this is a drug that may be used in the future, but I do want to emphasize it has a limited target population. It's only for moderate fibrosis. It's not indicated for advanced liver disease, not indicated for strictly fatty liver disease with no fibrosis. The side effects are minimal, and it has not been a major issue. I have prescribed this already several times, several patients, and I have not heard any adverse reactions. So again, the main hallmarks of metabolic fatty liver: abstain from alcohol, modify risk factors for cardiovascular metabolic disease, and weight loss. And most of these patients have elevated BMIs. Weight loss is the primary therapy for most patients with metabolic dysfunction associated liver disease. The recommendation is generally 10% of your body weight. That's the cutoff where we've seen improvement in histological parameters. So if you lose less than 10% of your weight, I think there's minimal change in liver histology. But these are sort of the main hallmarks. Again, what is necessary to do is identify high-risk groups. Which I emphasized already, the diabetes, the pre-diabetes, patients with increased cardiometabolic risk factors, patients who happen to have hepatic steatosis on imaging, and unexplained elevations in AST, ALT. These are the groups that you may want, you need to get a detailed history, exam, and focus on management of their cardiovascular risk factors as described in this yellow box. And then eventually do a fibrosis risk stratification. As I talked about the different markers we have, you can categorize them into low risk, intermediate risk, or high risk. And in summary, what can you offer these patients? Again, low risk, intermediate risk, high risk. It's based on the various objective parameters we have. We have FIB-4. We have stiffness measurement. And based on that, we can categorize them into advanced stage or early stage. If you see this box, summarize all the interventions, essentially across all level risks, lifestyle intervention is there, and if you go down to number 2, lifestyle, it requires physical activity, healthy diet, avoiding excess alcohol. So that's across the board. Weight loss recommendation is present. Obviously, it depends what their BMI is. Some, the patients with the higher risk need a very strong structured weight loss program. Across all anti-obesity medication should be considered, and bariatric surgery should be considered if they are indicated. And of course, pharmacotherapy for NASH, not in the early, and depending on the fibrosis level, you can consider. All need cardiovascular risk reduction, and diabetes is obviously always in the formula and requires management too. With the diabetes care, I usually defer that to primary care or endocrinologists. I do want to make one comment. Pioglitazone, which is not really used much by endocrinologists anymore. That was the one therapy that has shown to have some benefit in fatty liver disease. However, because it has a lot of risk, a lot of side effects, including edema, weight gain, so forth, I do not see pioglitazone prescribed too much as a first-line diabetes medication. And I think the current trend will be GLP-1 therapies. I think we went over all this. This is just a review of the algorithm and the emphasis on FIB-4 testing and determining of their risk factors. So in summary, general population-based screening is not advised. All patients with hepatic steatosis or suspected NAFLD, presence of obesity, metabolic risk factors should have undergo primary risk assessment and then surveillance. Patients with advanced fibrosis should abstain from alcohol completely. If there's a situation where testing is indeterminate, discordant, these patients should be referred to specialists for further secondary diagnostic evaluation. Again, diets limited in carbohydrates, saturated fats, and high fiber, such as Mediterranean fat, should be encouraged, not only for cardiovascular benefits, but also with fatty liver disease. And overall endpoint is to minimize risk factors to slow any progression of fibrosis, which is associated with the poor clinical outcomes. again, thank you again for your attention, and I think we will open this for discussion.
Thank you very much for an interesting presentation, which is indeed very much important to know what has been done, what is being done actually in advanced methodology of dealing with this condition. Well, we'll proceed with answering questions if the speakers do not mind. We had some questions preliminary sent to us, and some of the questions you can see in the chat box. Let's start from the preliminary sent ones. Actually, I will read in Armenian and then translate into English for your convenience. Well, first question is, որ աստիճանի ախտահարման դեպքում է հնարավոր տեսնել լյարդի ճարպային ինֆիլտրացիան ուլտրաձայնային հետազոտության ժամանակ. So the question is, at what level of disease can fatty infiltration of the liver be seen on ultrasound?
Yes, I think the way the ultrasounds are able to detect fatty liver disease, I think they can detect across most stages actually, and the way I've seen interpretations of ultrasound is that they usually will give us a mild, they will describe it as mild steatosis, moderate, or severe. So again, the way the ultrasound is working is it's you know, it's like shades of gray versus this is more pale versus more black. So it's echogenicity, and I think what the radiologist described is highly echogenic liver. So it looks more white, actually. The liver looks more white. That's when there's fatty liver. So I don't think there's a direct correlation because the standard ultrasound is not giving objective numbers. However, if you do that additional testing, as I described, shear wave elastography versus vibration-controlled elastography, there you get more objective numbers, and that's more relevant.
Okay.
May I comment also? Rafi, correct me if I'm wrong. Is it possible? I've heard that if the liver if the fatty liver is not moderate or severe, if it's, for example, if the fatty infiltration is less than 20%, the ultrasound might miss it. Again, it's dependent on the operator, but ultrasound seems to be more reliable in moderate and severe fatty liver rather than mild disease. Is that correct?
Well, I want to say my point of view of this is that no, I don't use ultrasound as a tool for fatty liver disease so much because, as I said, we have better objective markers. We can get actual scores. You know, as I described, the CAP score. So I think sometimes patients may have very minimal fatty liver disease, and the radiologist will describe fatty liver. So I think it's not the most accurate testing. I think if you get a report that says fatty liver on it, I think you should just use that as one component amongst many different data points that you have. I do want to say there are better tests, better imaging tests than ultrasound. So again, this is not available here, but or in a lot of places, but the gold standard, if you want to really get an imaging profile of your fat in the liver, is MRI. It's called PDFF, proton density fractionation. So this is also a new generation MRI testing, and it actually gives you an actual number, like a percentage of steatosis. That is by far much better than ultrasound, but not readily available and somewhat expensive to do.
Okay. Thank you very much. If I may continue, the other question is kind of continuation of related somehow to what you already covered just a minute ago. One of the participants asked if, considering the low and middle income context, can it be managed without FibroScan? And if indicated, what is the treatment protocol in this case?
Sorry, can you repeat the first part? If it, yes.
Considering low and middle income countries context, considering that FibroScan might not be freely
Available.
Yes, can
Yes,
it be
yes. So as I mentioned in the talk, alternatives are there. So I think even in the United States, you have to consider, we are a big country. There's a lot of rural places, lot of parts of the country where people live far from big cities. They have small community centers. So even in places like that, they're getting a FibroScan means they have to drive 2 hours, for example. So we know this. I mean, we acknowledge that. So that's why all the guidelines indicate you can do the FIB-4, which is well validated, which is readily available, which is lab test that you already have, or as I said, the standard ultrasound that you have, that obviously most hospitals, middle income countries also have ultrasounds. You can see, you can discuss with the radiology department there if they are able to add the elastography component, which is not a major expense. I think it's essentially a software upgrade on their existing General Electric package, and that could be used as additional information to assess fibrosis and steatosis.
Okay, thank you. Anything to add?
Oh, I was, it's an important question. These tests are expensive or not available. As Dr. Karagosian said, the FIB-4 score is available. You have the patient's age and platelet and AST and ALT. That's easy to calculate. And if the patient has a high FIB score and you're not able to get a FibroScan, if the patient has a high FIB score and there are metabolic risk factors, you should be highly suspicious that that person is on his or her way to fibrosis. So you have a high FIB score and metabolic risk factors, be very vigilant in controlling those risk factors because that person already has fibrosis or is on its way. So that makes us in primary care, even we should be more vigilant in treating those risk factors.
Of course, yes. The combination of high FIB-4, presence of those risk factors. Yeah, and sometimes, you will, if you can't do these non-invasive tests, you may end up getting and the patient has, you as a provider and the patient have concerns, and you want to provide certainty. And I've been in many situations like this. You want certainty, 100% certainty. You offer a liver biopsy. That's available, I think, everywhere. Yeah.
Okay, thank you very much. Let me move to the next question. Actually, in your speech, Dr. Karagosian, you covered already the benefits of Mediterranean diet, and also when we were covering the main lifestyle changes, you included the physical activity, the low carb diet, etc. One of the participants asked to clarify the efficacy of low carb diet, which is already covered, and intermittent fasting for this disease treatment without any additional medications.
Yeah, that's a good question. Again, I'm not a nutritionist, so this is a little bit outside of my scope. I mean, I have not seen strong data or evidence of intermittent fasting as a healthy intervention. I will defer to Dr. Ajaman. Do you have these conversations with
Oh,
your patients? Because I don't
thank
know
you.
what the data behind that is, particularly
There,
in this disease. I don't think there is strong data.
there is some data. Of course, the Mediterranean diet is number one.
Yes.
Because the Mediterranean diet not only has benefit against fatty liver, it also has, as we know, cardiovascular benefit. And these people are, most of them are not dying from liver cirrhosis. They're dying from cardiovascular diseases, right? I mean, the NAFLD, MASLD increases their cardiovascular risk. So that's why the Mediterranean diet is superior here. However, if somebody, I think any kind of diet that helps the individual lose weight does have beneficial effects on reducing fatty liver. That includes intermittent fasting, that includes low carb diet, that includes less evidence for DASH diet. When it comes to intermittent fasting is interesting. For some people, that's what works. They would like to only eat in certain intervals, like they eat for 8 hours. They won't eat for the rest of the day. It's practical for them. It's not for everybody. I don't recommend it for children. I don't recommend it for pregnant women. I don't recommend it for people who are on insulin. But if it's something that the person wants to try, it is very reasonable. And there is evidence for weight loss, and anything that helps the patient lose weight is beneficial.
Yeah.
But again, Mediterranean diet is superior.
No, I agree. I mean, I think the bottom line is what works to lose weight. That's the focus here.
Yes.
But the Mediterranean diet has been studied thoroughly, right?
Yes.
It's been studied thoroughly, and it's shown to have health outcome benefits across many diseases. So
True.
we prescribe that. But again, there's so many diets out there. It's hard to follow them right now, and that's why I did say having nutritional consultation, which we offer, of course, all these patients, we offer nutritional referral within our clinic. That is very helpful for them.
That's true. About the very low carb diet, though, please be cautious if you offer that diet to the patient. Make sure those individuals are going to eat more fatty foods and protein. Make sure that their fat is healthy fats, like they're eating fish and avocados and nuts rather than red meat and processed meats. So that becomes a problem. And if you're going to prescribe a very low carb diet, please make sure to watch their lipids because again, hyperlipidemia is associated with NAFLD, and therefore we don't want to worsen that condition while we're treating the fatty liver.
Thank you very much. Next question is related to endocrine conditions that are corresponding to fatty liver disease. Yeah. Actually, you already covered diabetes, but the question specifically indicates also thyroid conditions. Could you please elaborate a little more when thyroid conditions correspond to this particular disease? And let me really quickly tell this in Armenian and then continue with the answer. Հարցը վերաբերում է ոչ ալկոհոլային ճարպային հեպատոզի եւ ուղեկցող էնդոկրին հիվանդություններին, մասնավորապես մասնակիցը խնդրել է պարզաբանել ավելի շատ խոսել ոչ միայն շաքարային դիաբետի, այլ նաեւ վահանաձև գեղձին վերաբերող խնդիրների մասին. We can proceed.
Right. Thyroid diseases can cause liver abnormality for sure. It's not, as you can see, I had the slide that had the metabolic syndrome, the different metabolic comorbidities or risk factors. It turns out it's not in that list. The other ones are, the classic ones are, that one was not. But I do want to comment that outside of this metabolic syndrome, if you have thyroid dysregulation, you have thyroid disease, it's very possible that you may end up getting liver test abnormalities, the various types of liver inflammation and so forth. I've seen that, and oftentimes it's easily corrected when the thyroid disorder is corrected. Yeah.
Right. There seems to be, yeah, we do see a lot of people with hypothyroidism. I guess but I think if the question was about cause and effect, I don't know that there is any cause and effect between hypothyroidism and fatty liver, but of course they coexist. People who are hypothyroid may be overweight, and that's a risk factor. But as opposed to diabetes, there is direct relationship, and it's insulin resistance and all the inflammation. So that's a direct relationship, cause and effect. But with hypothyroidism, I'm not aware of cause and effect relationship, right?
Let me cover a couple of questions mentioned in the chat box, then we could move and continue with others mentioned during the registration. We have a question, which is the following. I will read in Armenian, then translate into English. Հնարավոր է արդյոք ավելի մանրամասն ներկայացնել մորֆոլոգիական քննությունը եւ չած սպեյնի դասակարգումը. So, is there a possibility to present a bit in more details the morphological assessment and also child's pain classification?
The child's, I'm sorry?
Child's pain, it's name of classification, if you're familiar with it or not. I'm not familiar with it.
There's a child's Pew classification. Is that what child's, are we talking about CHILD PUGA?
I don't think so, no. It's a name, Chad's. In Armenian, Cha Adesa pain.
Oh, the CHADS. Is this are we talking about the cardiovascular score? CHADS. I think I'm not sure, did you understand the question exactly? The CHADS score? I mean that's something for yeah.
Դասակարգումների մեջ հիմնականում չայլդի ավասի մեկրպյուի դասակարգումներն է, որը որ այս վերջի տարիներին դասակարգումը որպես է ձև չայլդպյուի դասակարգումը մորֆոլոգիական
Ներողություն, Child's Pew, որ խոսում են ինչպես Child's Pew?
Ցիրոզի,
այո, okay. Child's Pew, so
Parket Pew բանի համար էլի, ցիրոզների ու ասենք իրանց Child Pew-ի դասակարգումը հիմնականում որ
հասկանալի է. So ուրեմն բացատրեմ. So let me explain I think the question is Child's Pew. PUGH is the classification. So what this is like three categories: Child's Pew A, B, and C. And this classification really is a general classification for all types of liver disease. Okay, so it's not really unique or specific for fatty liver. Basically, it's really utilized when we want to understand how advanced the liver disease is. So, for example, a Child's Pew C means the patient has probably more than 50% chance of dying in 6 months, essentially. So that's like a high morbidity. Whereas a Child's A has compared to the general population probably has some increased risk of reduced life expectancy, yes, but there's no high probability of high mortality in like 6 months. So I think this wasn't really addressed in this topic because this is more this topic is more related to end-stage cirrhosis and so forth. Yeah.
Okay, thank you. If there's nothing to add, I would move to the next question. Okay. Next question in the chat box. Again, I'll read it in Armenian, then translate into English. Ինչ կասեք նիհար, բայց ճարպակալած լյարդ ունեցողների մասին, որքան հաճախ եք հանդիպում եւ հարցի մյուս մասը, թե ինչ կենսակերպային խորհուրդներ կտաք, արդեն ծածկվել է, այնպես որ առաջին մասը կասեմ. So what would you say about patients who are not overweight but have this condition? How frequently you meet these kind of patients?
Yes, of course. This is a condition called lean NAFLD. It's well described. It's not completely unheard of. So oftentimes this stems from genetic background, meaning certain patients with certain genetic predisposition may have lean NAFLD. Or it could be, you know, sometimes we have, and I'm always still surprised to see, but we have lean patients who have type 2 diabetes that sometimes does happen. I mean, I see that sometimes. So if there's diabetes and no obesity, we still have it. However, in particular, I see lean NAFLD in certain East Asian populations, for example, from China, Japan, Korea, who have somewhat of a different genetic makeup, and they may not be necessarily overweight by Western standards, but have fatty liver. So I think it exists. The management is probably similar, is likely similar. You know, you don't necessarily focus on weight as much, but you focus on metabolic risk factors.
Okay, thank you. Anything to add, Dr. Arjanian?
No, that I agree. We don't. Basically, it is. I don't see it a lot, but I've heard that it does exist. Yes, in lean people, and it's about Asian in the United States. It seems that NAFLD is also more common in Asians as well as Hispanics. So I don't know if you know, a lot of Asians are not very overweight or obese. So maybe there's something to that.
Mm-hmm. Okay, thank you. Next question from the chat box. In Armenian. Ինչ հաճախականությամբ է պետք հետազոտել լյարդը, եթե բուժարում ստանում է մետոտրեքսատ կամ նման հեպատոտոքսիկ պրեպարատներ? So at what is the recommended frequency of liver examination if patient takes methotrexate or other medications that are toxic to liver?
Yeah, so methotrexate, as we know, I mean, has nothing to do with non-alcoholic fatty liver, but it's a well-known toxic medication to the liver. I think, I mean, it's a medicine that's been around for a long time. It can cause drug-induced liver injury at any point of time of its usage. So I think if you're a physician who's prescribing methotrexate to your patient, I think getting liver tests every 6 months, at least in the beginning, getting it more frequently is necessary. And then over time, probably something like every 6 months to 1 year, to be safe, probably every 6 months to get liver tests. That's essentially all you need to do, because the manifestation usually will happen with increased elevation in liver enzymes. I don't think there's any particular protocols I'm aware of that says you have to do special scans for these patients every so often, but liver tests should be checked regularly.
Okay. It's a good question. Medications, as Dr. Karagosian mentioned in his lecture, drug-induced liver injury is part of the differential diagnosis. So we have to think about drugs. So in addition to hepatitis and alcohol, as he mentioned, in primary care, be careful about the common ones. Of course, chemotherapeutic agents, steroid use, NSAIDs, a lot of ibuprofen, Advil, you know, that can cause problems. So let's be more vigilant in their use. I did want to post another lecture, a conference actually, in honor of Dr. Rafi Hovanesyan. I just posted it in the chat box. And it is about liver cirrhosis, and perhaps that doctor who was asking about the the Pew score, child Pew score, maybe he can attend that. It would be helpful.
Actually, everybody was interested.
Oh, certainly.
Information that there is a great event. Thank you very much. The continuation of, like, the same person asked a second question. In Armenian it is ինչպես պետք է վարվել հսկել, երբ հեպատոզը զուգակցվում է հղիության հետ. So how should we proceed if pregnant woman has method?
Yeah, you know, I think it's no difference. I think maybe the question is referring to there's a unique condition that happens in pregnancy. It's called acute fatty liver of pregnancy. So this is actually different than what we're talking about today. So in general, I mean, you know, non-alcoholic fatty liver disease is a chronic condition that a patient will have many years. So 9 months of pregnancy, there's nothing different you have to do for that. But if the question is about acute fatty liver disease of pregnancy, this is a condition that is manifested during pregnancy, and it can lead to you know, acute liver failure and sometimes urgent need for delivery of the baby. So again, it's not relevant to this talk, but I think it's something that there's genetic predisposition. There's certain patients are genetically predisposed to have that. There's some genetic testing that can be done, and if a mother were to have that for, let's say, one of the deliveries and then first pregnancy, that has to be looked at subsequent pregnancies to be sure. So that's key for that. So I think it's two different things. The acute fatty liver of pregnancy is not necessarily a metabolic condition, more so a genetic condition.
Okay. Thank you very much. Anything to add, Dr. Ajamian?
No.
Next question was actually the following. Առաջարկվող պրեպարատը, որ երկրներում կան, արդյոք Հայաստանը ունի. So basically the participant was asking about the treatment medication. If I'm not mistaken, it was semaglutide. If it is available in Armenia, and I did a quick check according to National Registry of Medications, like link of which I am posting to all of you, just for your information. It was not there, but in case of there are people here who would like to share their experience with this particular medication, perhaps we could hear their experience. Կան մարդիկ, ովքեր սեմագլուտիդ դեղամիջոցի հետ երբևէ առնչվել են մեր երկրում Հայաստանում?
If you don't mind, I can answer. You should say in Armenian or in English. You choose.
It's up to you.
Okay, so as the question was in Armenian, maybe I should say it in Armenian, then translate. So
Go ahead.
Okay, հիմնականում Հայաստանում էնդոկրինոլոգներն են շատ օգտագործում սեմագլուտիդ դեղորայքը, իրանց կողմից շատ աննշանակվում ու Օզեմպիկ անունով է դա հայտնի, միգուցե տենց ավելի շատ տեսած լինեն բժիշկները, ու էնդոկրինոլոգիական պրակտիկայում շատ լավ օգտագործվում է, կոնկրետ Հայաստանում գաստրոենտերոլոգ հեպատոլոգները ավելի շատ ուղղորդում են, եթե ունենք շաքարային դիաբետ տիպ 2, ուղղորդում են էնդոկրինոլոգի մոտ ու էնդոկրինոլոգները շատ լավ վարում են դա Օզեմպիկով, այսինքն պրակտիկան Հայաստանում կա, միգուցե գրանցված չի դեղորայքը, ես դրանց ինֆորմացիա չունեմ, բայց ինքը ակտիվ օգտագործվում է Հայաստանում. maybe in English also.
Եթե կարելի է, ես էլ ասեմ, ես էնդոկրինոլոգ եմ ու շատ եմ օգտագործում Ozempic, Հայաստանում գրանցված չի Ozempic-ը, Հայաստանում դա դրսից են բերում պացիենտները կամ որոշ չգրանցված տեղերից կարողանում են ձեռք բերել։ Նույն սեմագլյուտիդը կա Ռուսաստանի Դաշնությունում Quincenta ու Semavi կանոններով, որը ավելի մատչելի է, մոտավոր կես գին է գալիս Ozempic-ի համեմատ, եթե դա ինչ-որ մի մասնագետի կհետաքրքրի։
Well, actually, it was already translated by the interpreter, but just a quick summary of what two experts from Armenia just said. It is being used in Armenia, though it is not registered. So it's used by endocrinologists pretty widely. Also, some analog of from Russia is available, which is half the cost of Ozempic. Okay, thank you very much. Next question from the chat box. If there is nothing to add on that. Okay. Next question. Իսկ հիվանդները, որոնց լյարդը ֆիբրոզի սկզբնական փուլերում է, adekvat բուժումից եւ կյանքի որակը փոխելուց հետո քանի տարի է ապրելիությունը գնահատվում միջինը? So if the patient is in the initial stage of fibrosis and has adequate therapy and also changes lifestyle, what is the average life expectancy in this case?
Yeah, I mean, it's a hard question to answer, but I think the way I would approach this is that if you're able to control your risk factors with cirrhosis, again, going back to that child's category, child A, meaning you have cirrhosis with no symptoms, what we call decompensation and no symptoms. Cirrhosis alone, the life expectancy, the data shows that it's slightly less than the average life expectancy of a patient with non-cirrhotic. But I think, but I would say at the same time, it's not very limited. So I think you can continue to have a normal functional life with cirrhosis as long as the patient hasn't transitioned to the more advanced cirrhosis state, where you develop ascites, which is fluid development, you develop things like portal hypertension or other complications, or even liver cancer. So the absence of those, patient may have a fairly good life expectancy.
Thank you very much. Next question. Արդյոք նշանակվում է L-կարնիտին կամ վիտամին B3 հիվանդներին? So is it a common practice to prescribe L-carnitine or vitamin B3 to these patients?
Yeah, I think the literature is not overwhelmingly robust or strong. There was some literature describing vitamin E to reverse liver steatosis. However, vitamin E high doses at 800 units a day is associated with other all-cause mortality data that was found, including bladder problems and things like that. So I think it's not really utilized as much. So my opinion on this is vitamin supplements are little harm. You can use them, but unlikely to alter the course of disease dramatically. I'll let Dr. Hashemian comment if he has anything about vitamins.
As you mentioned in your lecture, this disease is a spectrum, right? You got on the lower end, you have just fatty deposition, and then you have inflammation, you have oxidative stress, you have insulin resistance. So in the pathophysiology, there is oxidation, there's inflammation. So of course, people are gonna want to study antioxidants, right? All kinds of antioxidants, because if there is oxidation and inflammation that's leading to MASH, so can an oxidant be helpful? I mean, I'm sure more studies will come and maybe we'll know more. But like you said, vitamin E, there was some evidence of reduction of steatosis. It did not reverse fibrosis, I don't think, but it did improve the liver enzymes. But like you said, it has risks. High doses of vitamin E can actually falsely elevate your A1C level. So that's a problem if there's diabetes. It can also increase the risk of prostate cancer, and it can increase the risk of bleeding. So I would be cautious about that. I'm not aware of L-carnitine or any supplements being beneficial.
Thank you very much. Maybe maximum 2 more questions and we will sum up because we're already over the initially announced time. Question is the following, it's in English. When a patient's BMI is higher than 40, can the result of a fibro scan show a falsely elevated degree of fibrosis, even if fibroscan with CAP? Let me quickly translate. Եթե բուժարուի մամի զանգված ինդեքսը 40-ից ավելի է, արդյոք կարող է ֆիբրոսկանավորումը ցույց տալ ֆիբրոզի բարձր աստիճան, ոնց որ խաբուսիկ բարձր աստիճան, անգամ CAP ֆիբրոսկանի միջոցով.
This is a good question. Yeah, there's a limitation of fibroscans. The technology behind this, as I mentioned, is vibration waves. So that when you put the probe on the patient is feeling a vibration. This vibration is traveling from the skin to soft tissue, across the abdominal wall, muscles, liver. It's a wave. So the heavier you are, the more central obesity there is. Technically speaking, the physics behind the wave traveling may be altered. So even the manufacturer has stated that testing can be inconsistent. Results can be inconsistent with very elevated BMI patients. So then you should consider alternative non-invasive testing for that group. Possibly MR elastography.
Anything to add?
No.
Okay, thank you very much. And probably the last question, actually we covered, if I'm not mistaken, all questions in the chat box, and the majority mentioned in the registration form. Some of them were already addressed during the presentations, for example, modern treatment methods, how to act in case of ALT, AST elevated, etc., levels, etc. So probably the last question here would be if it can happen that newborn from the moment of being born has this disease, and even if it can be, intrauterus diagnosis, in Armenian կարող է պատահել, որ նորածին ծնվի եւ այդ պահից համարվի այս հիվանդությամբ հիվանդ կամ դեռ չծնված համարվի հիվանդ.
Well, my comment on this is there are very rare, uncommon pediatric. This is sort of congenital diseases of the liver or metabolic diseases of the liver that can cause liver problems from birth. They're rare, but they do exist. They can manifest in different ways, including excess fatty buildup of the liver. These are all unique diagnoses, very uncommonly seen, but in very specialized pediatric centers that exists. But I think what we're talking about today is more of a liver condition that happens from various metabolic risk factors that one develops over time. That said, a pediatric patient, let's say a teenager, and we've seen this many times. I don't know, Dr. Ajami, you've seen, let's say, a 15-year-old or a 13-year-old can have metabolic disease as well, and they can develop pretty significant, actually, fatty liver at that age. But to answer your question, I'm not aware of a newborn necessarily to have this problem.
Oh, I agree. I believe maybe the person questioning asking the question is referring to those inborn errors errors of metabolism. But you are right. As you know, as you all know, we're seeing more obesity in childhood now, and type 2 diabetes in children and adolescents now, and no wonder there's going to be an increased incidence of metabolic liver disease. Oops.
Yes, so inborn errors of metabolism, of course, they can manifest, but those are purely genetic.
Genetic, yes.
Yeah.
Asking if may I just have 1 minute to go back to the case that I presented, so basically, I don't need the slide. So basically, that individual, that 68-year-old woman with the slightly elevated liver enzymes. So after we heard from Dr. Karagosian, so what do we do with this patient? So we did a FIB score, and that person's FIB 4 score was elevated. It was 2.2. Which is an intermediate risk. And then, therefore, the next step was fibroscan. And the fibroscan score was high. It was 9, and in the F2, F3 range. So that's risky. So there is some fibrosis there. So the plan for that patient is, of course, number 1, focus on lifestyle changes. The healthy eating and exercise. When we, as in primary care, I think it's just not enough to tell people just go and lose weight and just eat better. I think we have to be a little bit more specific. So we can tell them about the Mediterranean diet, and we can learn what that means. We should just give them specific instructions, clear, simple guidelines. This is what I want you to eat. I want you to eat more olive oil, more avocados, more nuts, more whole grains, etc. And same with exercise. When we tell people, oh, you should exercise, okay, write it as a prescription. Just tell them 30 minutes moderate exercise. I want you to walk for 30 minutes 5 days a week. I want you to go to the gym and do weightlifting every other day, 3 days a week. So be a little bit more specific. I find that it is helpful our job is to guide them. Please don't preach them. That doesn't work. I've discovered myself. Don't tell them what to do. Just be a guide. Tell them what the guidelines are. Tell them you have fatty liver. That means there's 20% chance that you're going to get NASH. And then if you get NASH, there's another 20% chance of fibrosis, cirrhosis. So be specific, give the guideline. And instead of telling them what to do, sometimes it's helpful to ask them, okay, so what can you do about this? What can you change? Let them verbalize, let them come up with the answer. That is more effective. So let them tell you, all right, these are the things I can do. Oh, I can't do this. I can't exercise. I don't have time. So and then, so, all right, what else can you do? How can you get there? So I think that's very helpful. That's all I wanted to add.
Thank you so much for sharing this valuable experience. Actually, it is indeed very much important to work in a patient-centered manner, becoming a team in this transformation and this treatment process.
So I do want to add that this patient, if they came to our clinic, we would, and if they're failing, lifestyle modification or this lifestyle treatment, we would definitely offer a GLP.
Oh, definitely.
We would. I don't know if you're
yes.
you would do, because BMI is 34. And as you said, most likely it's going to stay this way for a while. It's not going to, unfortunately, patients are not very successful. A lot of them losing weight. So, and the comorbidities have occurred. So we would offer that. Yeah.
Oh, definitely for this patient, GLP-1 RA. And of course, her blood pressure is 140. We should be more aggressive with that. And the dyslipidemia, her LDL was 135. So we should address that. Oh, definitely.
Okay. Very well. It's almost 6 p.m. in the US, 11 a.m. in Armenia, and 11 a.m. in the US, almost 2 hours. It took almost 2 hours. And I would like to sum up the event. Thank you very much, first of all, dear experts, for being here, sharing your valuable experience, and serving as good role models. And, being present here during this event. Thank you very much for accepting the invitation. Thank you very much, colleagues from Armenian American Medical Association, and thank you very much, the donor, for this generous donation. And thank you, participants, dear participants, for being here, actively participating in this event, actively asking questions. We do hope that it was interesting and beneficial. By this, I would like to sum up the event and actually stop the recording. Let me stop it before we continue with the event evaluation.
Yes, I do want to also thank you, Asli, for doing an excellent job in moderating this discussion. It was very engaging, very informative. I always learn also from these conversations, and enjoy learning from practices in different areas. Again, thank you again for the AUA and the Armenian American Medical Association for coming together and organizing this. I think this is a program that we should continue on a regular basis with various different, topics. I think it's a good way to connect from here to Armenia, and I hope that the relationships continue.
Thank you very much. Thank you.
Yes, thank you, Dr. Atanyan, and thank you, Dr. Karagosian. It was very informative. I learned a lot from this lecture too.
Thank you yourself. I liked the questions. I liked how you posed the case report and everything like that. It was very intriguing. Thank you.
I enjoyed it.
Thank you. Let me stop the recording.